Hello, everyone, and welcome to Unit 2. Unit 2 is technically just communication and patient safety and quality. However, I know that we weren't able to touch on patient education, so that is why I am including that in this video. Now, these topics are foundational nursing concepts that you will use in literally every patient interaction, regardless of specialty. Whether you work in med surg, pediatrics, ICU, hospice, right? All the others, you will constantly educate patients, communicate therapeutically, and make safety based clinical decisions. Now, these concepts are also heavily tested on the HESI exam because they're considered core nursing judgment skills. Many students think communication and safety questions are easy because they seem straightforward. But these are actually some of the most commonly missed questions because HESI treats prioritization, therapeutic communication, and patient centered care very carefully. As we go through this lecture, I want you to think about two things. One, what would this look like in a real patient scenario? And two, how would HESI test this concept? I'll point out major HESI concepts throughout the lecture as we go along. Now, patient education is one of the most important roles nurses have. Nurses are educators during every shift, whether we formally realize it or not. You educate patients when administering medications, reviewing discharge instructions, teaching wound care, explaining procedures, discussing lifestyle changes, reinforcing safety precautions, or answering questions about diagnoses. One important thing to understand is that patient teaching is not just giving information. Effective teaching requires assessment, planning, implementation, and evaluation. Many patients may nod their head and say they understand when actually they do not. That is why evaluation of understanding is critical. One of the biggest mistakes students make clinically is overestimating patient understanding. Patients are often overwhelmed, anxious, distracted, fatigued, or even embarrassed to admit confusion. As nurses, we need to create an environment where patients feel comfortable asking questions. For HESI, remember, teaching is only successful if learning is verified. There are three primary purposes of patient education, and HESI frequently asks students to identify which purpose applies in a scenario. The first is health promotion and disease prevention. This occurs before illness develops and focuses on maintaining wellness. Some examples can include smoking cessation, exercise programs, nutrition counseling, blood pressure screenings, vaccinations, or even safe sex education. The second purpose is health restoration. This occurs after illness or injury and focuses on returning the patient to optimal functioning. Examples for this include post-operative teaching, physical therapy exercises, medication teaching after hospitalization, or teaching a patient how to care for a surgical incision. The third purpose is coping with impaired functioning. This focuses on helping patients manage chronic disease or permanent limitations. Again, examples for this would include insulin administration for diabetes, oxygen management for COPD, adapting after a stroke, or learning to live with heart failure. A HESI strategy here. Pay attention to timing and patient condition. So, prevention is before illness, restoration is recovering from illness, and coping is long term adaptation. The Joint Commission developed the Speak Up initiative to encourage patients to become active participants in their healthcare. Patients have the right to ask questions, to understand treatments, participate in decision making, and speak up if something feels unsafe. As nurses, we should encourage patients to advocate for themselves. Now, this slide also discusses how teaching mirrors communication. Teaching is not a one-way process. Just like communication requires feedback, patient education requires evaluation. The gold standard method for evaluating learning is teach back. Teach back means the patient repeats the information in their own words or demonstrates the skill. For example, instead of asking, "Do you understand how to take this medication?" we would ask, "Can you explain to me how you will take this medication once you get home?" Or we can say, "Can you show me how you'll use your walker safely?" Teachback helps identify misunderstandings immediately. HESI absolutely loves teachback questions. If you are asked how a nurse evaluates understanding, teachback is usually the correct answer. Now, there are 3 domains of learning nurses must assess and incorporate into teaching. The first is cognitive domain. This involves knowledge and understanding. So, understanding medication instructions, learning the disease process, or explaining signs and symptoms to report. The second is the affective domain. This involves feelings, emotions, attitudes, beliefs, and values. Patients may intellectually understand information, but emotionally struggle to accept it. For example, a patient newly diagnosed with cancer may understand the treatment plan cognitively, but still feel fearful, angry, or overwhelmed emotionally. The third is psychomotor domain. This involves physical skills and motor performance. So, insulin injections, dressing changes, ostomy care, walker use, or even inhaler techniques. For HESI, students often miss questions because they only focus on one domain. Strong teaching plans frequently combine all 3: understanding, emotional acceptance, and physical performance. Now, not every patient is ready to learn at the same time. Motivation refers to how important the patient believes the information is. Patients are more motivated when they understand the benefits, the risks, and how the information impacts their life. Self-efficacy is very important here. Self-efficacy means confidence in one's ability to perform a behavior successfully. Patients with high self-efficacy are more likely to adhere to medications, make lifestyle changes, and participate in self-care. Readiness to learn refers to emotional and physical readiness. A patient in severe pain, actively nauseated, maybe sedated, or highly anxious is not in the best state for learning. Now, the ability to learn includes a multitude of things. It includes cognition, literacy, developmental level, hearing, vision, language, and physical capability. For example, a patient with severe arthritis may cognitively understand insulin injections, but physically struggle to perform them. When you're looking at HESI, we always want to assess barriers to learning before we start teaching. The environment in which we teach significantly impacts learning success. Think about even when you're studying, right? We want an environment that is quiet, comfortable, well lit, and free from distractions. Emotionally, the patient should feel safe and respected during this time. Patients with low health literacy are especially vulnerable to embarrassment or shame. Sometimes patients pretend to understand because they do not want to appear uneducated. Timing is also critical. Teaching should occur when the patient's pain is controlled, when anxiety is reduced, and the patient is alert enough to concentrate. One major nursing mistake is trying to rush discharge teaching right before the patient leaves the hospital. HESI often tests whether the nurse chooses the best timing for education. So, this is where, let's say our patient is going for surgery. That discharge teaching should happen before the patient even goes into surgery to make sure the patient is ready to accept it and it's something they have already heard before after surgery. Now, on this slide, we are comparing the nursing process with the teaching process. Students sometimes confuse these because they follow similar steps, but they are not exactly the same. Now, the nursing process we are going to go more in depth with next week, but just as a little introduction to it, the nursing process is broader and focuses on the patient's overall healthcare needs. So, the steps that we use are assessment, diagnosis, planning, implementation, and evaluation, which in nursing school we often abbreviate that to ADPI. This process guides all nursing care, not just education. The teaching process, however, focuses specifically on the patient's learning needs. It still follows a systematic approach, but the focus is narrower. For example, before teaching a patient how to administer insulin, the nurse should assess what the patient already knows, their literacy level, how is their vision, how is their dexterity, are they emotionally ready, and are they willing to learn? Only after assessment can the nurse appropriately plan the teaching session. One major HESI concept here is that assessment always comes first. HESI frequently asks, what should the nurse do first? Students often pick an intervention immediately, but the correct answer is commonly assessment based if we don't have the big picture already there in front of us. For example, before teaching about a low sodium diet, the nurse first assesses the patient's current dietary habits and understanding. Remember, you cannot individualize teaching without assessment. Health literacy is one of the strongest predictors of patient outcomes. Now, low health literacy affects medication adherence, discharge success, chronic disease management, and hospitalization rates. We often see that patients may struggle to read labels, whether it be food labels or medication labels, understanding their prescriptions, following detailed instructions, or even interpreting their own symptoms. So, as we are assessing our patients, here are some signs of low health literacy. If we're noticing our patient has incomplete forms, if they are missing appointments, misusing their medications, or even saying things like, oh, I forgot my glasses. Now, in order to help some of these issues that we see in our practice, as nurses, we should use plain language instead of the medical jargon that we learn and use in nursing school. Meaning, like I just said, avoiding that medical terminology, speaking slowly, using visual aids, and again, that gold standard, using teach back. Another key concept is simple before complex. We want to teach the most essential survival information first before going into all of those little tedious details that may come with some of the disease processes that we encounter. Before we begin teaching, we first have to assess the patient. One of the biggest mistakes students make, again, both clinically on HESI exams, is wanting to jump directly into teaching without first evaluating the patient's learning needs. Teaching is not one size fits all. A teaching plan should always be individualized based on the patient's condition, readiness, abilities, and preferences. On the left side of the slide, we have the key areas nurses should assess before teaching begins. First, assess the patient's current level within each learning domain. Remember from earlier that the learning domains are cognitive, affective, and psychomotor. We need to determine, what does the patient already know? How do they feel emotionally about the situation? And are there any physical limitations of performing the skill? For example, a patient may cognitively understand how to administer insulin, but still feel emotionally overwhelmed or physically struggle due to arthritis or maybe a vision impairment. Next, assessing the patient's knowledge of their health condition. Never assume the patient understands their diagnosis or treatment plan. Patients often misunderstand medical terminology or have incomplete information from previous healthcare encounters. Then we assess learning style and preferences, just like we do in nursing school as we're preparing to learn all of this information. So some patients learn best through demonstration, some through written materials, verbal discussion, repetition, or maybe some visual aids would help. A patient's preferred learning style can significantly impact how well they retain information. Now, we also assess physical and cognitive readiness. A patient in severe pain, highly anxious, fatigued, sedated, or confused is unlikely to learn effectively. As we stated, timing also matters greatly in patient education. Lastly, assess anxiety and comfort level. Anxiety can block learning because patients may be too emotionally overwhelmed to process information. Creating a calm, supportive environment improves learning outcomes. Now, looking at the right side of the slide, once assessment is completed, the nurse can begin planning the teaching session. The first step is selecting the topic and level of instruction based on the assessment findings. Teaching should match the patient's current understanding and abilities. Next, as we stated, we have to determine the best time for teaching. So, we already talked about pain control, if the patient's fatigued, right, the emotional state, but we also have to take in consideration any sort of medication effects. Think about your opioids, for instance, right? Immediately after receiving pain medication, or right before, let's say, a patient's getting discharged, may not be the ideal teaching moment because our patient isn't going to be the most cognitively there. We also need to take into consideration any interruptions that are going to happen. If we know that in 10 minutes we have to go to a nursing huddle, well, depending on what we're teaching our patient about, those 10 minutes might not be adequate, and we don't want to try to rush through that education. The nurse should then choose approaches that help the patient progress within the learning domains. Different patients may require different strategies to build understanding, that emotional acceptance, or those psychomotor skill performance. Lastly, the patient should remain actively engaged throughout the teaching session. Passive learning is usually less effective. Patients and students learn better when they participate, ask questions, demonstrate skills, and verbalize understanding. Now, pay close attention to the HESI tip at the bottom because this is extremely important for exam questions. Assessment drives the teaching plan. On HESI exams, again, when you see questions asking, what should the nurse do first? The correct answer is often an assessment-focused intervention before teaching occurs. HESI loves prioritization questions involving assessment before intervention. So, I know I've said it a million times, always think, assess first, then teach. Now, this slide summarizes the biggest patient education concepts that you need to know for HESI and clinical practice. I know that I have said these already with the last, 25 minutes at exhaustion, but there's a reason for it, I promise. The first concept is teach-back. Teach-back is considered the gold standard evaluation method because it verifies patient understanding. Instead of asking, "Do you understand?" the nurse asks the patient to explain or demonstrate the information. So, can you show me how you will use your inhaler at home? This allows the nurse to identify misunderstandings immediately. The next key point is addressing all three learning domains: cognitive, affective, and psychomotor. Many students focus only on the cognitive domain, meaning that knowledge aspect. But patients also need emotional acceptance and physical skill performance. Another major concept is self-efficacy. Patients who believe they are capable of successfully performing a health behavior are much more likely to follow through consistently. Finally, health literacy significantly affects outcomes. Right? We said that low health literacy increases risk for medication errors. It increases risk for readmissions, complications, and unfortunately, poor disease management. So, what can we do as nurses? We can improve understanding by using that plain language, limiting medical jargon, using visuals, and using that teach back. One very important HESI reminder is the order of assess, diagnose, plan, teach, and then evaluate. Patient education questions often will follow this exact sequence. All right, moving on. So this section introduces therapeutic communication, which is, again, one of the most important skills in nursing. Communication impacts patient trust, patient safety, emotional support, interdisciplinary collaboration, and patient outcomes. Many communication questions on HESI are scenario based. You are not just memorizing definitions, you are selecting the best nursing response. As we move forward through this section, focus on which responses are therapeutic, which responses block communication, and how nurses adapt communication for different patients and different situations. One important thing to remember is that therapeutic communication is patient-centered, not nurse-centered. The goal is to encourage expression, build trust, and support the patient emotionally while still maintaining professionalism. So, in this section, we are going to focus on foundations of communication, communication models, nurse-patient relationships, therapeutic communication techniques, and communication with special populations. As we go through this section, constantly ask yourself, does this response open communication or shut it down? Communication in nursing is much more than simply talking to patients. Every interaction requires critical thinking. As nurses, we constantly analyze information, interpret patient behaviors, recognize concerns, and make clinical judgments in real time. We do not just hear words, we interpret the meaning behind them. For example, a patient may say, "I'm okay," but their body language, the tone, or even their facial expression may suggest anxiety, fear, or sadness. Nurses must assess both verbal and nonverbal communication. Looking at the left side of the slide under what it involves, the first point is interpreting messages from patients and colleagues. Nurses must evaluate communication carefully to identify misunderstandings, any safety concerns, or emotional needs. The next point is obtaining and verifying clinical information. As nurses, we should never make assumptions. We verify our information through assessment, clarification, observation, and communication with the healthcare team. Another important skill is correcting misinformation, but doing it with compassion. Patients may misunderstand diagnoses, their medications, or the treatments they're going through. Nurses should provide education respectfully and therapeutically without making patients feel embarrassed or judged. Finally, critical thinking helps nurses make patient-centered decisions based on the patient's condition, their preferences, safety needs, and emotional state. Now, looking at the right side under caring and communication, communication is not only about exchanging information, it is also about building trust and supporting patients emotionally. Being fully present during interactions helps patients feel heard and respected. We should encourage patients to express both positive and negative feelings in a safe, non judgmental environment. Now, instilling faith and hope does not mean giving false reassurance. Instead, it means supporting patients realistically while remaining compassionate. We also promote patient advocacy by protecting our patients' rights, supporting informed decisions, and speaking up for patient safety, especially when our patient can't do so for themselves. At the bottom of the slide, notice the reference to Watson's theory of human caring. This theory emphasizes empathy, compassion, therapeutic presence, and holistic care. For HESI, I want you to remember that best nursing responses are usually therapeutic, empathetic, patient-centered, and supportive of open communication. Now, we know that nurses communicate constantly throughout every shift, but communication does not always occur in the same way. This slide reviews the 5 levels of communication nurses use in healthcare settings. Understanding these levels helps nurses adjust their tone, their communication style, and approach depending on the situation and audience. The first level is intrapersonal communication. This is communication within yourself, your internal thoughts and self-talk. We use intrapersonal communication for reflection, decision-making, self-awareness, and recognizing personal biases. For example, before caring for a patient, a nurse may internally reflect on personal feelings or assumptions to ensure those biases do not affect patient care. The second level is interpersonal communication. This is one-on-one communication between two people and is the most common level used in nurse-patient interactions. So think about during patient interviews, discharge teaching, the therapeutic communication we talked about, and conversations with family members. Strong interpersonal communication is essential for building that trust and therapeutic relationship. The third level is small group communication. This occurs when nurses communicate within a group setting, such as team huddles, maybe during interdisciplinary rounds, care conferences, or shift report discussions. In these situations, communication must remain organized, clear, and collaborative to support patient safety and continuity of care. The fourth level is public communication. This involves communicating with larger audiences through community education, formal presentations, staff education, or public health teaching. Nurses may use public communication when providing health education in schools, clinics, or community programs. The fifth is electronic communication, which we do use a lot. It plays a major role in modern healthcare communication. So think your electronic health record documentation. Telehealth visits are up and on the rise. Emails, patient portals, and secure messaging systems. Now, although we are communicating electronically, this communication must still remain professional, accurate, confidential, and therapeutic. Hesse often gives a scenario and asks students to identify the level of communication being used. Now, the two most commonly confused types of communication are intrapersonal and interpersonal. Remember, intrapersonal is within yourself. Interpersonal is between two people. For example, if a nurse reflects internally before entering a patient room, that is intrapersonal communication. If the nurse speaks directly with a patient, that is interpersonal communication. The circular transactional model is a model that reflects how communication actually occurs in real life. Communication is not simply one person talking while the other listens. Instead, both individuals continuously influence each other throughout the interaction. The sender and the receiver both interpret messages, provide feedback, and adjust communication in real time. This model also reminds us that communication includes both verbal and nonverbal messages. So, a patient may verbally say they understand discharge instructions, but their facial expression or body language may suggest confusion or anxiety. Feedback is one of the most important components of communication because it confirms whether the message was understood correctly. Channels refer to how communication occurs. So this could be through spoken words, written communication, our body language, touch, electronic communication, and a plethora of more ways, right? But knowing that there are different ways in which we can communicate. Now, noise refers to anything that interferes with communication. This can include physical noise. Maybe the patient is in pain, or maybe they're anxious about their diagnosis. Cultural differences is a big one. Language barriers, or emotional distress. For Hesse, feedback and communication barriers are heavily tested. Now, we touched on the fact that communication involves much more than just the words we say. Nurses must pay attention to both verbal and nonverbal communication because both provide important information about a patient's condition, emotions, and understanding. Starting with verbal communication on the left side of the slide, verbal communication includes both spoken and written words. One important element is vocabulary. We should always use language the patient can understand, avoiding excessive medical jargon or complicated explanations, especially when teaching patients with low health literacy. So, for example, instead of saying, "You have hypertension," it most likely is going to be more effective to say, "Your blood pressure is high." Another part of verbal communication is pacing and tone. How we say something matters just as much as what we say. Tone can communicate calmness, urgency, frustration, empathy, or reassurance. Patients are often very sensitive to tone of voice. Now, clarity and brevity are also important. Nursing communication should be clear, direct, and concise. Overloading patients with too much information at once can increase confusion and anxiety. Timing and relevance are also essential. We talked about that even important information may not be effective if delivered at the wrong time. So, when we're talking about teaching, we use the example of how a patient in severe pain or emotional distress may struggle to process that teaching. Now, looking at nonverbal communication on the right side of the slide, this nonverbal communication includes everything except spoken or written words. So, facial expressions, our posture, eye contact or lack thereof, touch, gestures, tone, and physical proximity. Nonverbal communication is often unconscious, meaning patients and nurses may not even realize they are communicating messages through body language. One very important point is that nonverbal communication often reflects true feelings more accurately than verbal communication. So, if a patient verbally says, "I'm not nervous," while avoiding eye contact, wringing their hands, or appearing tense, the nonverbal cues suggest anxiety despite the verbal statement. So, those nonverbal communication or ways that a patient might communicate nonverbally can contradict verbal communication, which is why we as nurses must assess both together. When verbal and nonverbal communication conflict, nonverbal communication is generally considered more accurate. HESI may ask which cue the nurse should prioritize, and the correct answer is often the nonverbal behavior. So, if a patient says they understand discharge instructions, but appears confused or hesitant, the nurse should further assess understanding rather than assuming comprehension. Every nurse-patient relationship follows a natural progression through 4 phases. Even brief patient encounters move through these stages. Now, understanding these phases help nurses build trust, communicate therapeutically, establish professional boundaries, and provide patient-centered care. So let's look at the first phase of pre-interaction. This occurs before the nurse even meets the patient. This is when we review the patient chart, we gather that information, reflect on personal feelings or biases, and prepare mentally for the interaction. So, we might review the diagnosis, looking at the patient's lab values, their medications, or any previous documentation before we enter that room. Self-awareness is also important during this phase. We should recognize any personal biases or assumptions that could affect patient care. The second phase is the orientation phase. This is the introductory phase where the nurse first meets the patient. The main goals during the orientation phase are to establish trust with our patient, introduce ourselves, explain our role, set expectations, and begin developing rapport. This phase helps patients feel more comfortable and safe. So we want to make sure that we're introducing ourselves by our name, right? Any procedures that we're going to do, we want to explain before we do them. We want to discuss goals of care and answering any questions our patient may have. The third phase is the working phase. This is usually the longest and most active phase of the relationship. During this phase, the nurse identifies problems the patient has. We implement interventions, provide that teaching we talked about, encourage self-care, and use therapeutic communication techniques. Most direct patient care occurs during the working phase. Now, this is also where trust and collaboration continue to develop. The fourth phase is the termination phase. So this is when care is ending. So if a patient is being discharged, if they're being transferred to a different unit, or if it's the end of the shift and you're going to be going home for the day. During this termination phase, we should summarize progress that we see with the patient. We should evaluate outcomes, reinforce any teaching provided, and prepare the patient for transition of care. One important thing students sometimes misunderstand is that termination does not mean the relationship failed. Termination is a normal, planned conclusion to the therapeutic relationship. Think about if we didn't have this termination phase, right? You finish what you're doing in the patient's room, and all of a sudden you abruptly walk out. Well, your patient is most likely going to be left confused and wondering what the heck just happened. Now, at the bottom of the slide, notice that HESI tip. HESI often describes a nurse's action and asks which phase is occurring. So, examples, going through them again, reviewing the chart before meeting the patient, pre-interaction. Introducing yourself and establishing goals, orientation. Providing interventions and teaching, working. And preparing for discharge, termination. When answering these questions, focus on the nurse's primary action within the scenario. Now, the SACCIA is a communication framework designed to improve communication among healthcare team members and reduce patient safety errors. Okay, so each letter stands for something different within this communication framework. The first component is sufficiency. This means providing enough information for safe decision making. Incomplete handoffs can lead to errors and missed care. Accuracy means information must be correct, current, and verified. Nurses should never guess or communicate unverified information. Clarity means communication should be direct and easy to understand. Avoid vague statements and confusing terminology. Contextualization means placing information into the patient's full clinical picture. This helps providers understand why the information matters. And then interpersonal adaptation means adjusting communication based on the audience. As nurses, we communicate differently with physicians, patients, family members, and coworkers. This framework connects closely with SBAR communication and patient safety. SBAR is that framework that we use a lot of the times to talk with providers. Not saying that is the only time we use it, but SBAR stands for situation, background, assessment, and recommendation. For HESI, clarity and accuracy are especially important. I know I've said it probably an annoying amount, but effective communication in nursing must always be patient centered. This means that nurses adapt their communication style based on each patient's age, culture, abilities, emotional state, and individual needs. Patient centered communication focuses on understanding the patient's perspective rather than using the same communication approach for everyone. At the top of the slide, notice the emphasis on self awareness and curiosity about the patient's experience. Nurses must remain aware of personal biases and avoid making assumptions about patients based on their age, their culture, their diagnosis, the language they speak, or their background. Now, looking first at communication with older adults. When we're speaking with older adults, we should use a calm pace, clear communication, patience, and active listening. Older adults may need extra time to process information. We should have reduced distractions. And they also may need assistance with hearing or vision deficits. So before we assess or teach, we want to ensure that if they have hearing aids, they're using them. Do they need glasses? Or are there any assistive devices to help them function properly during the education? Encouraging older adults to share life experiences or reminisce can also help build rapport and trust. Now, what I will say, real world side, sometimes that is something that a patient does not want to do. It can bring up some pretty heavy feelings depending on what is being reminisced on. So that is where we use that critical thinking and judgment to determine, is this appropriate for the patient that is actively in front of me? Next are patients with sensory impairments. So patients with hearing or vision impairments may require communication modifications, such as written instructions, visual aids, touch when appropriate, or assistive devices. We should listen carefully without interrupting and allow additional time for communication. Now, looking at language barriers, this is a major patient safety issue. Certified medical interpreters should always be used when communication barriers exist. Family members should not be used as interpreters because information may be filtered. Maybe medical terminology is misunderstood, and patient privacy may be compromised. When using an interpreter, nurses should speak directly to the patient rather than speaking to the interpreter. Additionally, when using an interpreter, going back to the idea of teach back, right? We're still going to look or use teach back to confirm patient understanding when using an interpreter. Lastly, the slide discusses personal biases. Nurses must continuously reflect on personal beliefs or assumptions that could interfere with equitable care. Intrapersonal reflection helps nurses provide respectful, culturally sensitive, and patient centered communication. When communication questions involve special populations, the correct answer will usually prioritize patient dignity, safety, therapeutic communication, and mutual understanding. For example, if a patient has a language barrier, the safest nursing action is to obtain a certified interpreter rather than relying on family members or assuming understanding. Now, this slide covers one of the most important communication topics for both clinical practice and HESI exams: therapeutic versus non therapeutic communication. Therapeutic communication helps build trust, encourage patient expression, strengthen the nurse patient relationship, and support emotional well being. Non therapeutic communication, on the other hand, can shut down communication, increase anxiety, damage trust, and make patients feel dismissed or judged. So, starting on the left side, let's look at therapeutic techniques. The first is active listening. Active listening means giving the patient your full attention. So, this includes maintaining eye contact, limiting distractions, listening without interrupting, and showing genuine interest in what the patient is saying. Patients can usually tell when healthcare providers are distracted or not fully engaged. Next are open-ended questions. These encourage patients to elaborate and share more information. For example, tell me more about how you've been feeling. Open-ended questions help gather more complete information and promote therapeutic conversation. Reflection involves repeating or restating the patient's feelings to encourage deeper expression. So, if the patient says, "I'm scared about my surgery," the nurse could respond, "You're feeling anxious about what might happen." This also goes into a bit that clarification, where clarification helps ensure the nurse correctly understands what the patient means. So if the patient says something and we want to ensure that understanding, we might ask, "What do you mean when you say the pain feels different?" Now, silence is also therapeutic. In my personal opinion, as a nurse and as an educator, I believe that silence is one of the most beneficial therapeutic tools that you can have in your therapeutic communication toolbox. Many students, or just people in general, feel uncomfortable with silence, but therapeutic silence allows patients time to think, process emotions, and continue sharing. Empathy involves acknowledging feelings without judgment or false reassurance. So, saying something like, "That sounds really difficult," it can go a lot farther than what you think. Then, summarizing helps review important points and confirm mutual understanding before ending the conversation. Now, let's switch over to the right side of the slide, where we're going to look at non therapeutic communication techniques. False reassurance includes statements like, "Everything will be fine." Now, Although these responses may seem comforting, they can minimize patient feelings and create unrealistic expectations. Giving advice is also non therapeutic because it takes decision making away from the patient. So, if we say, if I were you, I would, well, that's putting our ideas into the patient's head rather than allowing them to think about it on their own. Changing the subject redirects attention away from the patient's concerns instead of addressing them. Asking why questions may make patients feel defensive or judged. So, for example, why did you stop taking your medication? Even with myself saying that, right? It takes you back a bit, like you feel like you need to defend yourself. Now, approval or disapproval places personal judgment on patient choices rather than remaining therapeutic and objective. Stereotyping involves making assumptions about a patient based on their age, culture, diagnosis, or background. Lastly, defensive responses occur when nurses focus on protecting themselves or the healthcare system rather than addressing patient concerns. Now, at the bottom of the slide, notice the reminder that these blocking techniques damage therapeutic relationships and should be avoided. For HESI, communication questions are often asking, which response is most therapeutic? The correct answer is usually the response that acknowledges feelings, encourages further communication, avoids judgment, and keeps the conversation open. If you see answers like, don't worry, everything will be fine, or why did you do that? Those are often signs of non therapeutic communication. Okay, so again, going over HESI communication tips. When answering HESI communication questions, choose empathy first. We have to make sure that we're acknowledging the patient's feelings, keeping communication open, avoiding judgment, avoiding advice giving, and we prefer open-ended questions. All right, now this slide highlights the major communication concepts we discussed and how they apply to nursing practice. Communication is essential for patient safety, trust, teamwork, and compassionate care. First, nurses must think critically during every interaction by interpreting verbal and nonverbal cues, assessing understanding, and making clinical judgments. Second, nurses should communicate with caring by being present, listening actively, showing empathy, and advocating for patients. Third, self-awareness is important. As nurses, we should recognize personal biases and eliminate non-therapeutic communication habits. Finally, nurses should evaluate outcomes by assessing whether the patient understood the information and felt heard and supported. Therapeutic communication is a skill that improves with practice and experience. For HESI, the best communication responses are usually empathetic, patient-centered, and focus on keeping communication open. All right, we're almost there. We are now transitioning into patient safety and clinical judgment section. This is one of, again, the most important areas of nursing because patient safety impacts every aspect of care. As nurses, one of our primary responsibilities is preventing harm. This requires strong clinical judgment, critical thinking, communication, and ongoing assessment. So, in this section, we'll discuss vulnerable populations, fall prevention, environmental hazards, mobility assessments, psychosocial safety factors, and restraint safety. Many HESI and NCLEX questions focus heavily on safety and prioritization. These questions often ask which patient is the highest priority, which intervention is safest, what should the nurse do first? As we go through this section, focus on identifying risk factors, least restrictive interventions, patient-centered care, and safety priorities. Remember, on HESI, the correct answer is usually the one that best protects patient safety while still respecting patient dignity and autonomy. Now, patient safety is not just about identifying physical risks. Nurses must also understand how the patient personally views safety and independence. For example, a patient may refuse a walker because they fear losing independence, even though the nurse recognizes a high fall risk. Effective clinical judgment requires nurses to balance patient autonomy, safety concerns, cultural beliefs, and emotional needs. We should use therapeutic communication to explore the patient's perspectives before immediately enforcing interventions. For HESI, the safest answer is often the one that acknowledges the patient's feelings first, then addresses the clinical risk. There are certain patient populations at greater risk for injury and complications due to physiological, developmental, or social factors. Infants and children are vulnerable because they lack hazard awareness and depend on caregivers for safety. Older adults are at increased risk due to reduced mobility, sensory decline, chronic illness, and polypharmacy, meaning that they have a lot of different medications they take. Patients with chronic illness may have decreased functional ability, which also increases injury risk. Underserved populations may also face barriers such as limited healthcare access, reduced resources, or decreased health literacy. For HESI prioritization questions, patients with multiple risk factors are usually the highest priority. Now, although we might be dealing with these patients in the hospital or a clinic, we assess both hospital and home environments for safety hazards. Major environmental hazards include vehicle accidents, poisonings, falls, and fires. So, patient education should always be individualized based on risk factors. So, let's take an older adult living alone. They may require focused teaching on fall prevention, smoke detector safety, and safe medication storage. So, some of the hazards that we should assess for are loose rugs, poor lighting, clutter, and unsafe heating devices. For HESI, prioritize teaching based on the patient's greatest safety risks. Now, as we saw, safety risks vary depending on developmental stage. Infants and toddlers are at risk for choking, falls, and poisoning because they explore their environment without understanding danger. Adolescents are more likely to engage in risk-taking behaviors, substance use, and unsafe driving practices. Adults may face occupational hazards, stress-related risks, and motor vehicle injuries. And then our older adults commonly experience falls, medication errors, sensory decline, and cognitive impairment. For HESI, match the safety intervention to the patient's developmental stage. Now, we use a lot of different tools for a lot of different things within our nursing practice. We use mobility assessment tools to objectively evaluate patient mobility and fall risk. The BMAT, or Banner Mobility Assessment Tool, evaluates bed mobility, sitting balance, standing ability, and walking. This helps nurses determine the level of assistance needed for safe movement and transfers. The TUG test, or Timed Up and Go test, measures mobility and fall risk. During this assessment, the patient stands from a chair, walks 10 feet, turns, returns to their spot, and sits down. Now, important to remember, a score of 12 seconds or greater indicates increased fall risk. I'm going to say that again because I know I tripped over my words. A score of 12 seconds or greater indicates increased fall risk. So for your HESI questions, remember that BMAT guides safe patient handling and TUG evaluates mobility and fall risk progression. Now, these fall risk assessments should occur throughout hospitalization, not just during admission. Patients should be reassessed on admission, yes, but also after a condition change, after a fall, and during transfers. The major fall risk categories include age, fall history, elimination habits, medications, mobility, and cognition. Patients with multiple risk factors require more aggressive safety interventions. For HESI, altered cognition combined with high-risk medications is a common high-priority scenario. Now, procedure-related accidents are often preventable when nurses follow safety standards consistently. Interruptions significantly increase the risk for medication and procedural errors. So, to reduce this risk, as nurses, we should minimize distractions, avoid shortcuts. I cannot emphasize that one enough, avoiding shortcuts. Following institutional policies, and using safety checklists. I remember as a new nurse, whether it be a new procedure that I was doing with a patient or a medication I hadn't given before. Before going into the patient room, I would either print out the hospital policy or I'd create myself a little cheat sheet to use while I was in the patient room to make sure I was hitting everything I needed to prevent any errors. Now, no interruption zones during medication preparation are commonly used to improve patient safety. So, if you're interrupted during medication administration or a procedure, the safest action is usually to stop and restart the safety process. Now, we talked about a lot of physical factors related to safety, but safety is influenced by more than just physical risk factors. Psychosocial factors such as health literacy, culture, beliefs, and perception of risk also affect patient safety behaviors. Patients with low health literacy may misunderstand discharge instructions, medication labels, or safety precautions. Cultural beliefs may influence whether patients accept interventions or even report symptoms. And patients who do not believe they are at risk are less likely to follow precautions. Now, if a patient refuses a safety intervention, the nurse should first assess the patient's understanding and perception before escalating the issue. All right, now restraints. Restraints should always be the last resort. Evidence-based practice supports trying less restrictive interventions first. So, some alternatives can include diversional activities, de escalation techniques, calming communication, orientation strategies, and sensory interventions. These approaches may reduce agitation without restricting patient movement. For HESI, remember the sequence of trying alternatives, document failure, obtain an order, apply restraint if necessary, and monitor closely. Restraints are rarely the first correct answer. Now, there are times when restraints are necessary, and when they are, nurses must carefully monitor patient safety. Before restraints are applied, assess for possible causes of agitation, such as pain, hypoxia, electrolyte imbalance, medications, or even confusion. Now, a provider order is required for restraints, and documentation must clearly explain the clinical need. While the restraints are in place, nurses monitor the placement, circulation, skin integrity, pulses, sensation, color of the skin, and also temperature of the skin. The restraint should allow room for 2 fingers underneath. And those restraints should also be removed and reassessed regularly. Typically, the order for a restraint is good for 2 hours. Then, after those 2 hours, we take the restraint off, we assess all of those things I just listed, and if the restraint is needed again, the order is replaced. For HESI, restraint monitoring questions commonly focus on circulation and skin assessment. as everything that we do in nursing care, safety interventions should always be individualized to the patient. Nurses should distinguish between actual risks and potential risks. Understanding the patient's daily routines can help identify hidden safety concerns. So, for example, a patient who frequently gets up at night may need improved lighting or assisted devices to reduce fall risk. Now, patients are more likely to participate in safety interventions when they are involved in the planning process. For HESI, assess the patient's willingness and ability to make changes before implementing interventions. All right, now this slide summarizes the major patient safety concepts from this section. So, key points to remember for HESI. Always considering both patient perspective and clinical risk. Recognizing patients with multiple vulnerabilities as highest priority. Remembering the tug cutoff of 12 seconds. Knowing fall risk categories. Reassessing fall risk frequently. Using restraint alternatives first. And assessing psychosocial factors that influence safety. Now, the patient safety questions that you see on HESI often combine prioritization, clinical judgment, communication, and patient-centered care. We always choose the safest and least restrictive intervention first. All right, this concludes the lecture then for Unit 2. So, as you are preparing for this section of the exam, remember those different education techniques and the fact that we need to assess the patient's need before we just start blindly educating. Looking at therapeutic communication, and when you're looking at the responses of what you can choose for your HESI questions, think, does this response open communication or does it shut it down? And for your patient safety and clinical judgment section, focus on fall prevention, safety prioritization, restraint precautions. And for all sections, everything should be focused on patient-centered care. Thank you, everyone, and I will see you next week in person for lecture. Please let me know if you have any questions, comments, concerns about the material that was presented during this video. Otherwise, I will see you all next week.